Thank you for joining us today for our workshop on epidemiology and health outcomes. Your workshop chairs today are myself, Anna Fano, and Jenna Sykes. We're both biostatisticians. I work at Seattle Children's Research Institute in Washington, and Jenna works at St. Michael's Hospital in Toronto. We don't have any disclosures to announce. We'd like to welcome all of our wonderful presenters for today. We're going to be starting out with a presentation from Dr. Liz Cromwell on patterns in lung function in children with CF. Liz is the Director of Biostatistics with the CFF Patient Registry Research Team and previously was an assistant professor at the Institute for Health Metrics. We'll then move on to a presentation from Anushka Palapana on the patterns and impact of environmental exposure on lung function decline. Anushka is a PhD candidate at the University of Cincinnati and a graduate student intern at Cincinnati Children's Hospital with Dr. Rhonda Sesniak. She came to the US from Sri Lanka to pursue her doctoral studies in 2016. We'll then have a presentation from Dr. Margaret Rosenfeld on a summary of 10 years of newborn screening in the US. Margaret is a professor and associate vice chair for clinical research at the University of Washington, as well as physician liaison to the Washington State Department of Health for CF newborn screening. Following Margaret's talk, we'll hear from Dr. Sriram Vaidyanathan on the prevalence and effectiveness of treatments for South Asian CF patients. Sriram is an instructor in the Department of Pediatrics at Stanford University and has been working on developing a universal CFTR correction strategy applicable to all CF patients, in particular those who cannot be treated using modulator therapies. Finally, we'll have a presentation by Dr. Adele Coriotti on the comparison of CF survival between Canada, France, Australia, and New Zealand. Adele is a postdoctoral fellow with Dr. Anne Stevenson in Toronto at St. Michael's Hospital, with a research focus in pathophysiology of patients living with CF, as well as the secondary complications of underlying respiratory disease. So thank you for listening in, and we'll go ahead and start with the first presentation.
Thank you so much for attending my talk today. I'm going to discuss use of latent class mixed models to identify patterns in lung function among a group of children with cystic fibrosis. My name is Liz Cromwell. I'm the Director of Biostatistics at the Cystic Fibrosis Foundation. I work on the Patient Registry Research Team, and I have no relationships to disclose other than being an employee of CFF. For background, I think there's general consensus that CF presents as a spectrum of disease, and some individuals may experience what could be described as milder illness, and others experience far more severe outcomes. And there have been many studies on this topic trying to understand the variation in CF-related disease in the population. I would argue that prior studies could be classified into quite broad categories. The first is any method that tries to use many patient characteristics or many different variables to identify groups. So this could be anything from clinical scoring approaches to cluster detection methods. And the intent here is to take highly multidimensional data and use that information to assign people to groups where individuals may be similar to one another across many different predictors. Another set of approaches would really, I think, could be described as anything that attempts to identify groups using one or maybe very few patient outcomes or characteristics. And that drives the group assignment, having similar outcomes or similar distribution of data on a subset of very small or one single variable, and then exploring whether or not there are predictors associated with those group assignments. When we first worked on this project, we did implement cluster detection methods, and that's been presented at a prior NACFC. While that analysis was successful in identifying groups, we ultimately found that the group assignments still had quite a bit of overlap, and we thought there was some limitations to how well we could differentiate individual subjects using the group characteristics. So we wanted to see if lung function data could be used instead to identify subgroups within our broader CF population. There were three specific aims of the study. The first was to see if whether or not lung function measures could be used at all to identify phenotypes or subgroups using registry data. To do this, we obtained lung function measures reported from age 6 to under 19 years of age in a cohort of children born between 1997 and 2001 with a confirmed diagnosis of CF. We chose these birth years to ensure that children would reach age 6 in 2003 or later, because this is the year that encounter level pulmonary function testing started being reported in the registry. We also wanted to make sure we captured outcomes through late adolescence. So these individuals also have the opportunity to reach 18 years of age in our study. We did exclude children who had late CF diagnoses after age 2, as well as those missing substantial pulmonary function testing data or were lost to follow-up. We wanted to finally, in the second aim, look at how well group assignment would agree across different measures of lung function. And we focus on the 4 reported in the registry: FEV1, forced vital capacity, FVF 25 to 75%, and the FEV1 FVC ratio. These were all modeled in terms of percent predicted according to the GLI reference equations. And in the third aim, we wanted to identify whether or not risk factors were associated with being assigned to a given group. We had about 3,000 children in our lung function group analysis, and then controlling for those, or removing those rather, who did not have sufficient predictor data. We had about 2,500 children to explore group assignment risk factors for the FEV1 analysis. To implement this approach, we used a method called latent class mixture modeling. And essentially what this approach does is assume that while there's a broad pattern of lung function that we can look at over age in the total group of people with CF, that this is really composed of a mixture of patterns based on a latent or unobserved variable. So we implemented this approach separately for each of the 4 outcomes listed here. Each model included age as the independent predictor, and we included a spline to give some flexibility to the fit between the relationship in lung function over age. The strengths in this approach are really that we can leverage repeated measures as reported through the CARE model. So cluster detection methods are somewhat inherently cross-sectional in that you really have to kind of define a single point in time in which you want to assign groups. And we wanted to leverage the longitudinal nature of our data. We also thought this method had some opportunity to explore uncertainty in an individual's group assignment because that can be quantified. And finally, we hope that group detection will be anchored in an outcome that has clinical significance. In terms of limitations of the approach, selecting the best model from this method is a bit subjective, and I'll describe that in the next slide. And we do have to implement a 2-step process to subsequently identify predictors associated with group membership. So to give you a sense of how this approach works, if you look at the left on this figure, where we have age on the x-axis and FEV1% predicted on the y, this is all the observations kind of visualized in our data set. So sort of a big cloud of data, not really easy to tease out any kind of relationship within this, from this kind of 30,000 foot picture. If we look on the right, what we're essentially doing is asking the model to search for common trajectories within the population. And so we implement this approach iteratively. So we test for the number of groups we wish to detect. So we start with 1 and we test all the way up to 5 groups. We also increase the complexity of the model by adding both a random intercept and then a random slope. So after we fit all these models, we look at the fit statistics to determine which is the best representation of the data. In terms of results, I'm going to focus on FEV1 just for the sake of time. We did find a 4-group model to be the best fit for percent predictive FEV1 using a random intercept for the child in that model. You can see here in the blue line, the sort of mean predicted group trajectory that the model has estimated. Underlying that are all the individual children who contributed observations, which are visualized in the individual lines that kind of show up in yellow to orange. The color gradient there represents the model probability that a child belongs to that group. So you can get a sense of how confident the model is for any one child, whether or not that's really where they should be classified. The top 2 figures, the top 2 rows, we can see the best and better. And this is really just a way to label these groups so that we can compare them across the other outcomes. And this is really just looking at the mean prediction by age 18, the best being the group with the highest FEV1% predicted by age 18, and the worst being the group with the lowest by age 18. I will note really what the model is doing is searching for common trajectories. And so it's not necessarily going to bin children with the same absolute FEV1 values together. And you can see that there's quite a bit of variation in terms of children with very low values versus very high values in all of these categories. What we're really looking at is whether or not kind of the change over time is fairly consistent in terms of the pattern observed among these children. You can see that the majority of our subjects were classified in the top 2 groups with about 10%, just under 10% in that worst category on the bottom right. I think it's a lot easier to visualize these when the curves are superimposed on one another. And so the top left corner, you can again see our FEV1 results. And there's quite a bit of variation if we look at the results for each group's prediction by age 18. For FEC and the FEV1-FEC ratio, we also identified a 4-group model, and you can look at the trajectories illustrated here. The yellow, bright yellow line represents that best group. So these would have the highest predicted lung function by age 18, and the dark blue is the worst. The FEF 25 to 75% category on the bottom right of this figure, we only identified 3 groups for this model. And I will note that we only have data available from age 8 and older for this population due to when this variable was added to the registry. If we go back to our FEV1 model results, we can also look at how well group assignment is concordant across the different outcomes. And so I'll draw your attention to this figure here on the right. Essentially, the way to interpret these charts is to look at the FEV1 group, which is indicated on the x-axis, and the proportion of those children who are assigned to the corresponding group based on these other 3 measures of lung function. So in this case, if we look at the far right here, just around 80% of the children who were assigned the worst to the worst category for FEV1 were also assigned the worst category in FEC. And if we go to the far left, where these are our best FEV1 assigned children, most of them are either in the best or better category for FEC. So what we would like to see is sort of this kind of visual pattern where we have taller bars, so to speak, in the yellow and orange categories on this best column, and much taller bar for dark blue or light blue in the worst and worst categories on the far right. We don't see as much of a direct overlap in the FEF category, particularly because this was a 3-group model, whereas FEV1 is 4 groups. But overwhelmingly, most of the children who were classified in that worst category for FEV1 were in one of the 2 lower categories on FEF. So I think in general, we have fairly consistent agreement kind of overall, but it's most certainly not a one-to-one correspondence for all children across all metrics. To look at risk factors, I've presented a slide that just describes some of our subject characteristics at age 6. And this just gives you a sort of a descriptive flavor for whether or not the classifications we detected based on FEV1 kind of align with what we would expect to see in terms of clinical presentation. So the children who are classified as best have higher overall mean BMI percentile compared to those in the worst category. They have higher lung function. They also have a lower percentage who've ever tested positive for MRSA or Pseudomonas compared to the worst category, which is a higher proportion of those children have ever tested positive. This worst category has a higher mean number of pulmonary exacerbations from our annualized data, as well as more medication use. The worst category also is a slightly higher proportion of Hispanic subjects compared to the best. To look at risk factors associated with FEV1 group membership, we employed multinomial logistic regression to estimate the probability of group membership. The best FEV1 group was selected as our reference category, and we used backwards elimination to select predictors, and really focusing here on predictors measured at age 6 in our final model to kind of decide whether or not any of these factors might explain why a child might belong in one group or another or be associated with. I don't want to imply any kind of causal relationship. This was very much a predictive kind of exploratory analysis in terms of testing for associations. We are not inferring any kind of causal effect with this approach. The variables associated with FEV1 group membership at age 6 in terms of their results for the model are presented here as odds ratios. And as you remember, the best FEV1 category is our reference group. So this can be a little clunky to interpret, but if we take a look at the odds ratio for sex, looking at the worst category here, I would interpret this as males have 0.6 times the odds of being in the worst category compared to females relative to what we saw in the best category. So weight percentile was statistically significant and associated with like a higher weight percentile, less likely to be in these lower lung function categories. More hospitalizations and years testing positive for Pseudomonas increased your risk of being in the worst or worst categories as well. One of the nice things about this model is that we can actually calculate predictive probabilities using the estimates from the model in terms of the various characteristics that are included. And so if we look at this figure, the best way to interpret what you see here on the right is to look at for every 1 year that a child reports Pseudomonas positive cultures. So 0 would mean they've never tested positive, 6, they would have tested positive every year, inclusive of age 6. As they have more kind of history of Pseudomonas positive culture surveillance, you can see that the probability that they belong in the best category or the better category declines, and the probability that they belong in the worst or the worst also increases. And so using the different variables that are included in the model, we can actually explore the influence of patient characteristics on kind of how the probability of group assignment might change. So in conclusion, we were able to identify subgroups of our pediatric cohort using lung function measures. The agreement between lung function measure was somewhat varied, but fairly consistent, particularly between FEV1 and FVC. And we noticed that a history of positive culture surveillance in early childhood is a fairly strong predictor of group membership, but sex, weight percentile, and parental education and hospitalizations were also important. I'd like to wrap up by acknowledging my collaborators, Wayne Morgan and Christopher Goss, who provided incredibly valuable insights into this topic and really supported the work from the very, very beginning. Elisa Fink and Jocelyn Strenga, my colleagues at CFF, have also contributed immense understanding of the registry data and support to analysis. Thanks also to members of our Comparative Effectiveness Research Committee who provided input. And finally, the Cystic Fibrosis Foundation patient registry participants and our CF-centered care teams who have really put in the time and the effort to make sure these data are reported and available for analysis. So many thanks to you all and also for your attention today during this presentation.
Thank you, Liz. That was a really interesting presentation. We do encourage people to submit questions if you have any. I do have one I could start out with. I was just curious on, you mentioned you used goodness of fit statistics. How many groups did you start out hypothesizing you would find for different patterns of trajectories? And was that similar to what you thought you would find?
That's a great question. Thank you. The other work that's been done on this topic have previously identified 3 groups using slightly different methods. And so that was sort of our initial hypothesis that we would either find 3, possibly 4. And so what we looked at, and one of the nice things about the approach is that we can also quantify the probability that groups have been assigned and look at the agreement, what proportion of kids are classified to each group, and also differentiate in addition to standard model fit statistics like EIC criteria, for example, by looking at how well the model is actually differentiating. That was really the core of our question, was like, can we differentiate these registry participants from one another? And so looking at the model results, we're really identifying the models that did the best at really trying to tease apart group membership.
Perfect, thank you. We did get a question in. Would it make sense to examine the impact of SES using a proxy such as income by zip code?
I think that's a great question, particularly since these data are from a much older set of birth cohorts. We would have to extrapolate their zip code data from the time that they were seeking care at their specific center. And I'm not entirely sure how accurate that is at classifying individual patient level SES status. I know that we have looked at that with more recent registry data. I think we have looked a lot at parental education in this analysis because we do collect that data over time and have looked at that. And I do notice a signal in terms of parental education. And I'm interested in exploring if it matters whether it's either parent's level of education or specific to father or mother, but I haven't dived into that in any detail yet.
Okay, we got another question that kind of builds off of that one. Were there other factors you looked at, or only the ones you presented, and then suggestion of medications, liver tests?
And that's also a great question. We have looked at other predictors, notably things that we have in our complications field in the registry. Some of the challenges with this particular age range, the distribution of kids, the proportion of children overall that have reported complications is pretty low. And so I think there may just be limited ability to look for a signal there. We did also look at predictor data at age 3 and haven't found a lot of differentiation between the values we have in the registry with group membership at that specific age. And I think, I'm just looking at the question again, things like Dornies alpha usage has been associated with, I did find an association with, the worst FEV1 group, but that's also could just be indication bias in that population. So I think we have to be cautious about using medications as a potential predictor of group membership.
Right, thank you. Another question we received is, did you evaluate any potential cohort effect across the latent classes?
I'm not entirely sure what the question specifically aims, but I don't think so, no.
Okay. Right, because your data came from the registry, correct?
Mm-hmm. It's a pretty narrow range of birth years.
Perfect. Well, I think that may be wrapping up our Q&A, unless we have any last minute ones that come in. But definitely an interesting study. I'm probably going to email you afterwards to get more information.
Great. Well, thank you so much.
Great, thank you.
Hello everyone, I'm Anushka Palipana. I would like to present our work on monitoring and phenotyping rapid cystic fibrosis disease progression using community characteristics and environmental exposures. The following relationship exists related to this presentation. In this presentation, we will be discussing what rapid decline of lung function is. Then we will discuss how we can phenotype rapid decline during pediatric disease progression and how we can monitor rapid decline risk throughout lifespan, accounting for environmental influences. In phenotyping, we examine the global changes in lung function decline, while in monitoring, we examine the secondary lung function drops. So, what is rapid decline? Rapid pulmonary decline is characterized by an initial drop in lung function that is sustained over time, which occurs predominantly during adolescence and early adulthood, but typically recurs throughout lifespan. Although associations of clinical or demographic characteristics with rapid decline have been widely studied, the impact of environmental influences are largely unknown. On the right, you can see an example pediatric patient whose lung function was relatively stable in his adolescence, but had a rapid decline in his early adulthood. Both our analysis cohorts are from US Cystic Fibrosis Foundation Patient Registry. For pediatric phenotyping, we consider patients who have provided at least 7 longitudinal measurements to the registry between ages 6 and 21. Longitudinal data can be considered as noisy, sparse functional data. Therefore, clustering these data can be achieved through functional data analysis technique called Functional Principal Component Analysis, or FPCA. FPCA can extract common temporal characteristics of a set of curves. In order for this clustering method to account for environmental influences, the FPCA technique we use should accommodate at least one covariate. For life course monitoring, we use patient records in CFTR collected at or older than 6 years of age. We use a linear mixed effects model with a nonlinear covariance structure. To identify potential predictive geomarkers, clinical and demographic characteristics, we use a method called Bayesian penalized regression in the form of an elastic net, or BEN. Now let's walk through pediatric phenotyping. These are the geomarkers we will be focusing on. Geomarkers are community characteristics and environmental exposures. There are 14 geomarkers here. These are acquired through different environmental databases by zip code tabulated areas and linked to CFTR data by using 5-digit residential zip codes. The means and the ranges of these variables are shown in this table. The FPCA method we use can currently accommodate only one covariate. So we performed PCA on geomarkers and collapsed these multivariate geomarkers to a univariate quantity. Then use the scores for the first principal component for each individual as a covariate in FPCA. So the highlighted ones in purple are strong positive loadings and green ones are strong negative loadings. So these strong loadings are the ones that contribute to the first principal component. As this principal component has strong positive loadings for traffic proximity, diesel particulate matter, respiratory hazards index, percent impervious, total crime, primary road density, and strong negative loadings for percent green, percent tree canopy, and secondary road length, this PC can be used as a proxy for negative environmental exposure. The fitted curves were clustered into three phenotypes: early, middle, and late, based on the scores for each individual from the first functional principal component. The leftmost column shows trajectories of FEV decline over time, which shows between and within patient variations. The middle column shows fitted patient-specific curves from covariate adjusted FPCA. It shows that all phenotypes, regardless of the phenotype, has a loss of lung function. And the rightmost column shows averaged fitted FEV1 trajectories for each phenotype. As you can see, the late phenotype has the highest lung function and the early phenotype has the lowest lung function. This table shows descriptive statistics for clinical and demographic variables. For continuous variables, we present mean and the range, and for discrete variables, we present the percentage, the frequency, and the percentage. Here, you can see as the diagnosis age increases, that the diagnosis age increases from early to late phenotype, the baseline age decreases from early to late phenotype, and the socioeconomic status, PA, MRSA, and CFRD, especially ever during follow-up, decreases from early to late phenotype. And here, a continuation of the same table shows that pancreatic enzymes use decreases from early to late phenotype, and BX770 modulator use increases from early to late phenotype, and the number of pulmonary exacerbations in the previous year at baseline decreases from early to late phenotype. This figure shows how FEV1 trajectories cut through the environmental exposure score. This is a 3D representation that allows us to look at the FEV1 trajectories versus age sliced through environmental exposures. When the principal component score in this axis is higher, the higher the negative environmental exposure is. So this figure shows that elevated negative environmental exposures were linked to increased FEV1 trajectories in younger ages, but decreased FEV1 trajectories in older ages. Average exposure levels for geomarkers with strong loadings were compared between phenotypes using ANOVA. Based on the results from ANOVA, we did pairwise comparisons. As you can see, all p-values except for middle versus late phenotype in total crime are less than 0.05. Therefore, at 5% significance level, we do not have enough evidence to support the claim that the means of crime in middle versus late phenotype is different. The main takeaway from the first chapter would be that the children and adolescents with the earlier rapid decline phenotype are more likely to reside in areas with more air pollution, more impervious spaces, increased crime, less tree cover, and limited green space. Let's move on to life course monitoring. This figure shows the motivation to use a linear mixed effects model with a non-stationary stochastic process. It contains FEV1 trajectories for all patients over time in gray and 5 example patients in red. It shows between and within patient variations, nonlinear and heterogeneous nature of FEV1 decline in CF disease progression. So in literature, it shows that these properties can be effectively captured by using a linear mixed effects model with a non-stationary stochastic covariance structure. And then we use the Bayesian elastic net to select the relevant predictors. This figure shows the selected clinical and demographic characteristics by a Bayesian elastic net in black. The shift here would be the direction of the change, and among the selected predictors on the left plot, the ones to the left of the line 0 corresponded to an overall decrease in lung function, and the ones to the right of 0 corresponded to an overall increase in lung function. The rate of decline of the plot on the right would be the slope of the change. Here, among the selected covariates, the ones to the left of the vertical line 0 would correspond to a decelerated lung function decline, and the ones to the right would correspond to an acceleration in lung function decline. Let me explain this a little bit more by taking number of PE events in the prior year as an example. Here, the increase of 1 PE in the prior year would correspond to this much of decrease in lung function adjusted for all other covariates, while for its rate of decline on the right plot, the increase in 1 PE in the prior year would correspond to increase in this much of accelerated in lung function decline. This figure shows the selected geomarkers from Bayesian elastic net in black. These coefficients can be interpreted in the same way as before. That is, the deprivation index, the percent green, primary road density would correspond to an overall decrease in lung function, while distance, ozone concentration, total crime, and percent tree canopy would correspond to an overall increase in lung function. On the right, the ozone concentration and distance would correspond to a decelerated lung function decline, and primary road density, percent green, and deprivation index would correspond to an accelerated rate of lung function decline. This slide shows model fit statistics and predictive performance of our model. Here, the full model is the model chosen by Bayesian elastic net, and null model is the model with intercept, slope, and baseline age. The predictors in the full model has indeed improved the fit statistics, AIC and BIC of the null model greatly, but the predictive performance based on this criteria has improved slightly. This slide shows individualized predictions for 2 patients using our model. The one on the left is a female pediatric patient with heterozygous F508 del mutation. On the right is an adult male patient with heterozygous F508 del mutation. The top row shows the predicted longitudinal trajectory in black, and observed FEV1 measurements are marked in red dots. So you can see the pediatric patient here has experienced rapid decline in her lung function compared to the adult patient. But our model has captured both cases well. On the bottom row, the predictive probability of a patient experiencing FIRES event is in red dashed lines. The actual FIRES events experienced by these 2 patients are marked by blue dots. A FIRES event can be defined as a FEV1 indicated exacerbation signal as defined by the CF learning network. So this model can be used as a tool in clinical decision making to monitor and predict lung function and predictive probability of a patient experiencing a FIRS event effectively. The main takeaway from the second chapter would be that several geomarker variables with clinical and demographic variables help predict the lung function decline in CF patients more accurately. In future, we are hoping to examine the associations of clinical or demographic variables with rapid FEV1 decline phenotypes, to examine additional sensitivities of modeling, and to implement risk monitoring at point of care. I would like to thank NACFC organizers and CFFPR committee, as well as my co-authors. Thank you all.
Thank you, Anushka. That was very, very interesting. While we're waiting for some questions from the audience, we have some from your chairs. First is, why was a Bayesian elastic net considered versus other techniques, and what else did you consider for that?
First, thank you for the question. So first we tried marginal testing by adding like one covariate at a time. That did not provide any specific improvement to the null model. So instead of performing, because Lasso can, the current R packages can accommodate only like regressions, not linear mixed effects models, but this is a newly implemented R package. So I think we thought that it's better to use that. That's why we stuck with the Bayesian elastic net.
Okay, that makes sense. We have another question from your chairs. So given that there's that correlation between tree canopy and green space and the deprivation index with socioeconomic status, how do you envision this information being used to inform patients and providers clinically?
For this application, provided that they are correlated, I think we can, I'm not sure how to answer that. For clinically, to use it clinically, maybe, I haven't looked into that, so I'm sorry, I can't answer.
No worries. It's definitely, I don't think there's necessarily a right or wrong answer. We did get a question here from Gabriella Oates. She's asking, did you use repeated / annual measures for all geomarkers, and were all geomarker data aggregated to zip codes?
We used the baseline data for geomarkers. We did not use aggregated data, but we actually used the residential zip codes for patients. They were linked to the CFFPR data by using residential zip codes.
Perfect, thank you. Well, I think that was all the questions we have, unless one comes in the last few seconds here. But thank you so much. Very interesting topic, very important topic too.
Thank you.
Thank you.
Hello, this is Margaret Rosenfeld from the University of Washington and Seattle Children's Hospital, speaking today on the real-world effectiveness of US CF newborn screening. Here are my disclosures related to this presentation. I'd like to begin by thanking the organizers for inviting me to speak here today. In terms of background, universal CF newborn screening was implemented across all 50 states and the District of Columbia by 2010. The Wisconsin randomized controlled trial of newborn screening demonstrated early and sustained improvements in growth, but no clear pulmonary benefits of newborn screening among infants born between 1984 and 1995. Evaluating newborn screening in the current era is important because we can look at the real-world effectiveness across multiple states and because CF care has changed so substantially since the 1990s. So our objective was to estimate the effect of CF newborn screening programs on longitudinal health outcomes a decade after universal newborn screening was implemented in the United States. We hypothesized that compared to infants diagnosed prior to the introduction of newborn screening in their state of birth, infants diagnosed after newborn screening was implemented would achieve improved growth, pulmonary function, and a delayed age at Pseudomonas infection. Here you can see a map showing the staggered implementation of newborn screening in the United States between 2004 and 2009, with a few smarter states implementing it actually before 2004. Now, we know that CF outcomes have improved over time due to better care and new therapies. So it's critical to account for these trends in order not to mistakenly ascribe improved outcomes due to newborn screening, when in fact it's the overall improvement in CF care that drives these changes. So how did we account for this in our study design? Well, we took advantage of the staggered implementation of newborn screening between 2004 and 2009 to be able to distinguish the impact of newborn screening from these known secular improvements in CF outcomes. We compared outcomes among children born in the same birth cohort, but pre versus post newborn screening implementation in their state of birth. We grouped states into 6 steps by year of newborn screening implementation. The primary exposure was born post versus pre-newborn screening implementation in the state of birth. So please note that this is a state level exposure. We didn't evaluate whether infants themselves were diagnosed by newborn screening, but rather whether they were born either pre or post newborn screening implementation in their state of birth. The outcomes were evaluated up to age 10 and included growth, that is weight and height percentiles, FEV1% predicted, which was only recorded in those greater than or 6 years of age, and then time to both initial and chronic Pseudomonas aeruginosa. Our inclusion criteria included a diagnosis of CF and born in the year 2000 or later in any of the 44 states that implemented CF newborn screening in 2004 or later. Exclusion criteria included if an infant was born in the year that CF newborn screening was implemented in their state of birth, as this was a transition period, or documented preterm delivery before 36 weeks. In terms of analysis, we used linear mixed effects models to estimate the effect of newborn screening on longitudinal weight and height percentiles, as well as FEV1% predicted up to age 10. All models included age, an interaction term between age and newborn screening group, a random intercept for state, and a random intercept for participant nested in state. Height and weight used a cubic term for age, and FEV1 used a quadratic term for age. Then we used time to event analyses to estimate the effect of newborn screening programs on the hazard or risk of incident and chronic Pseudomonas aeruginosa infection. And we used models both with and without excluding prevalent PA. In other words, removing those individuals who were PA positive at their very first culture recorded in the registry. Our covariates included birth cohort, CFTR functional class, minimal versus residual, sex, and insurance status at diagnosis. Here you can see the cohort size by outcomes. So there were about 9,500 eligible subjects, relatively evenly divided between the pre and post newborn screening eras. You can see that for height, weight, and Pseudomonas infection, we were able to use most of the cohort. But of course, for FEV1, there were far fewer eligible subjects because many of them had not attained the age of 6 during the study window. Here are the baseline cohort characteristics. And you can see that those born post-newborn screening tended to be born at later ages, had a much earlier median age at diagnosis, a median of 0 versus 4 months, with relatively wide interquartile range for those diagnosed conventionally. Those who were born post-newborn screening tended to be slightly less likely to be white and definitely more likely to be of Hispanic ethnicity, more likely to have public insurance, and more likely to have residual function mutations, though about the same proportion had at least one F5 white del allele. Here you can see that indeed in the post-newborn screening era, diagnosis was achieved much earlier compared to pre-newborn screening. So in the solid lines here, you can see that those diagnosed post-newborn screening were diagnosed much earlier than those in the pre-newborn screening era, and that this held up whether participants were homozygous for F508, the dashed line across here compared to here, or whether they had a residual function mutation here versus here, much more delayed in the pre-newborn screening era. Now we'll start to look at the association between newborn screening group and our longitudinal outcomes, weight, height, FEV1, and Pseudomonas status. So in terms of weight, you can see that those born in the post-newborn screening era had higher median annualized weight percentiles than those in the pre-newborn screening era, though this effect did tend to diminish over time. We found a very similar trend for height percentile, in that the median annualized height percentile was higher in the post-newborn screening infants compared to the pre-newborn screening infants, with that effect tending to diminish a little bit with advancing age. When we look at our linear mixed effects models, we see the same thing, not surprisingly. So weight was significantly greater in the post-newborn screening group, shown here, than in the pre-newborn screening group, showed here, though this effect tended to diminish over time. You can see more overlap in the 95% confidence intervals at later ages compared to earlier ages. Very similar for height, greater height in the post-newborn screening kids compared to the pre-newborn screening kids, with the effect diminishing with advancing age. When we look at FEV1, we have a slightly different story. First, I just wanted to show the number of available measurements by each year of age, 6, 7, 8, 9, and 10. For those in the pre-newborn screening who tend to be born earlier compared to post-newborn screening, you can see that the numbers drop out and get pretty sparse. When we look at the median annualized FEV1% predicted, you can see really no clear effect of newborn screening group. And when we look at this in our linear mixed effects models, we see that there was not a significant effect of newborn screening on FEV1% predicted, but we did see a significant interaction term. So that means that what effect there was did tend to increase with advancing age, so more separation between the two groups at later ages. When we look at Pseudomonas infection, we looked, as I mentioned, in the methods, both including prevalent Pseudomonas and excluding prevalent Pseudomonas. And we looked at both incidence, so first acquisition of Pseudomonas, and chronic Pseudomonas. And what you can see is that there was an apparent protective effect of newborn screening on both incident and chronic Pseudomonas, whether or not we included individuals whose very first culture was Pseudomonas positive. So for incident infection, the hazard was about 85 to 88% in those born post-newborn screening compared to pre-newborn screening, and looked more protective for chronic Pseudomonas, in which it looks like the risk was reduced by about a third with these 95% confidence intervals. So in conclusion, on the 10th anniversary of universal newborn screening in the United States for cystic fibrosis, we performed the first national longitudinal study of outcomes. Our study design took advantage of the staggered implementation of newborn screening to account for known secular improvements in outcomes over time, similar somewhat to a stepped wedge clinical trial design. We found significant increases in weight and height in the post-newborn screening infants compared to pre-newborn screening, and a lower risk of Pseudomonas infection, both initial and chronic. We did not see a clear effect on FEV1, though our sample size was smaller, as we only had values in those over 6 years of age, and longer follow-up might elucidate any association. I'd like to end by thanking my co-authors on the manuscript, particular Dr. D.B. Sanders and Liz Cromwell and Josh Ostrenga, but really everyone here, as well as the rest of the CF Foundation Patient Registry and Clinical Effectiveness Research Committee members, and the CF Foundation itself, the registry group, and all the patients who have contributed data to the registry, and the CF Care Center teams who, of course, enter all those data. Thank you very much. I'd be happy to take any questions.
Thank you, Margaret. Very interesting. We do have a question from Jenna, or my co-chair. Apologies if I missed it, but how many states only implemented newborn screens since 2004?
Yes, there were 44 states that implemented newborn screening in 2004 or later.
Okay, thank you. And then I have a question sort of based on an earlier talk at the NACFC here. Are there certain infants that are not picked up by the newborn screen that have CF, and what would you recommend for those infants?
Yes, there are absolutely false negative newborn screens, no matter what algorithm is used, because there are just some babies with CF who have a very low IRT in the newborn period. And in terms of what we would recommend, for what specifically?
Both, I guess, in terms of the gene panel that you would use, but also, what you would recommend for follow-up care. Yeah,
thank you for that question. So all states currently use an algorithm that involves both measurement of immunoreactive trypsinogen followed by DNA testing. And you can have a false negative for two reasons. One would be that the baby's IRT was below the cutoff used for that state in their newborn screening algorithm, and you're just going to miss those no matter what their DNA pathogenic variants are. And the second would be related to that not being captured on the panel. And there's just a huge variation in what panels are used in different states. There are commercial panels. A couple of states are doing next-gen sequencing. New York and California definitely do that. So the false negative rate can be anywhere between sort of 1% and 4%, something in that range. And those babies do tend to be diagnosed later. Some of them will have residual function variants and may not be set back so far by being diagnosed later. And then some of them definitely will have minimal function variants. And it's really a shame when those babies are missed. And then they come right into care, and we work aggressively to help improve their health outcomes.
Oh, that's really interesting. Thank you. We did get a question from the audience from Stephanie Chang. Do you have information on patient level exposures, such as whether they were diagnosed via newborn screen? Would you expect any differences in the results if you undertook that analysis?
Yeah, thank you for that excellent question. We do have patient level exposures. All of our data are from the registry, so we do know mode of diagnosis. But we specifically chose to ask the question, what is the effect of state implementation of newborn screening on algorithms? Then the question, what is the effect of individual mode of diagnosis on outcomes? Because we felt that was a more relevant public health question. So we did not choose to look at the mode of diagnosis, but rather looking at birth before or after implementation of newborn screening. It kind of gets back to your question a little bit, Anna, about false negatives, or for that matter, false positives. We just want to look at the whole screening program rather than how a particular infant was diagnosed.
That makes sense. And then if I can pick your brain, Margaret, if you had to give a nationwide recommendation for any improvements that you would like to see with newborn screen, what would it be?
Oh, wow. Well, to tell you the truth, I would like to see more resources for departments of health around the country set aside for newborn screening. Newborn screening in general, the number of conditions for which states are screening is just exploding. And yet the resources and staff, especially with setbacks during COVID, haven't gone up that much. And so newborn screening programs are just absolutely strapped. And when I talk to them, they're so cognizant that they're not able to do as good a job, say, at follow-up as they would like to because of not having enough personnel. So that would be my plea.
Great. Well, thank you so much. I think that was all the questions we have. Thank you very much, Margaret. It's very interesting.
Thank you for the opportunity.
Hello, everybody. Thank you so much for your invitation to present our work here. I'm super excited to be here. Today, I'm going to be presenting our study looking at the prevalence of CF in the Asian population and analyzing whether existing methods to diagnose and treat CF patients are effective in the Asian population. So we all know that CF is a disease that's really well characterized in the non-Hispanic white population. And we know that about 1 in 3,000 newborn babies who are non-Hispanic white tend to be affected by CF. And we also know that there are about 70 to 100,000 CF patients who are mostly concentrated in North America and in Europe. But we also know that CF affects people of other races, but it's just thought to be much rarer. So when you look at the NIH information page on CF, they would tell you that about 1 in 17,000 African Americans tend to be affected by CF, and about 1 in 31,000 Asian Americans tend to be affected by CF. And so it's really always been thought that CF is a very rare disease when it comes to Asians. However, at Stanford, we noticed that there were several CF patients who were of South Asian origin. And so this prompted us to go back to look at all of the Asian CF patients who have been treated in our center over the last 20 years. And indeed, we noticed that most of these CF patients ended up being South Asian. So this raises this fact that there's a large diversity among the people who originate in Asia, even though they're all sort of lumped together as Asians when we move abroad. But and South Asia, which accounts for India, Pakistan, Bangladesh, and a few other countries in that neighborhood, accounts for about 2 billion people in Asia. But then when you look at the rest of Asia, there are about another 2.5 billion people. And together they account for about 60% of the world's population. So it's a very diverse population. And then when you look at just the Asians around our local area, South Asians only form about 20% of the Asians. So it didn't make sense why 80% of our patients would be CF patients would be South Asian when they only account for 20% of the Asians in our local area. So this really raised this question of whether CF is much more prevalent in the South Asian population than we currently recognize. So the overall objective of our study was to look at the prevalence of CF in people originating from different parts of Asia, not just South Asia, and then look at the mutations that are present in these patients and analyze whether they are similar or different to the mutations that are present in the Caucasian population, and also analyze whether current methods to diagnose and treat CF are effective in Asians. So to pursue these objectives, we requested data from the registries maintained in the US, UK, and Canada. And we requested race and ethnicity data and the CFTR genotype of CF patients reported in these registries. And we excluded patients identifying as belonging to 2 or more races. And out of these 2 registries, the UK and the Canadian registries disaggregate South Asians from the other Asians, and we were unable to disaggregate Asian patients further, unfortunately. And then in the UK data set, we still have not been able to disaggregate any of the Asian patients. So today we won't be presenting any of the data from that registry data set, and we'll focus mostly on the data from the UK and the Canadian registries. So going to our first question on whether CF is much more common in South Asians, it does seem to be the case. So when you look at the UK registry, there are about 356 patients who identify as Asian. And out of these, 89% of them tend to be South Asian compared to other Asian. And when you look at the Canadian registry, you have a much smaller number of patients. There's only about 41 patients, but 70% of these patients of these Asian patients still tend to identify as South Asian. So then this raises this question of, are we just seeing this because there are just so many more South Asians living in the UK and in the Canada? So to assess this, we requested, or we just looked up publicly available census data set for the UK. And so we estimated the number of South Asians and other Asians living in the UK, and we calculated the prevalence of CF in both of these populations. So we estimate that CF affects about 1 in 13,000 South Asians and 1 in 75,000 South Asians based on the UK data set. And then we did a similar analysis using the census data set from Canada. And so here we estimate that CF affects about 1 in 75,000 South Asians and 1 in 250,000 other Asians living in Canada. And as you can notice, there's a wide discrepancy between the prevalence measures for both categories from the UK and Canada, and we don't know what is causing these discrepancies. However, when you look within the UK dataset and the Canadian dataset, it's pretty clear that South Asians do have a higher prevalence of CF compared to people from other parts of Asia. And this does have some implications globally, potentially. So South Asia has a large population, like we discussed in the beginning. So there are about 2 billion people living there. So if you look at the prevalence estimates from the UK registry, you're looking at a pretty large population of about 50 to 120,000 patients living in South Asia. And even if you look at the lower estimate from the Canadian registry, you're looking at a CF population that's almost as large as the CF population that you see in the UK, which has the second most number of CF patients in the world. So then this raises this question of, in this large population or potentially large population of CF patients, are the mutations causing CF the same as the mutations causing CF in the Caucasian population? And it's been widely reported that Asian patients tend to be affected less affected by the F508del mutation. And we know that about 90% of non-Hispanic white CF patients end up having the F508del mutation in at least one allele. And so we looked at what percent of patients in all of these registries end up having at least one allele with the F508del mutation. And both in the UK and in the Canadian registry, only about 40 to 50% of South Asians and other Asians ended up having at least one allele with the F508del mutation. And we also looked at our Stanford data set, and we saw a very similar observation in the patients being treated at Stanford. And this is widely consistent with most previous reports that have looked at the same question in the Asian population. So then this raises the other question of, if it's not F508del, what are the other common mutations affecting South Asians? And we really didn't have that information reported previously on that. So we looked at both the data from the UK and the Canadian registries. I'm showing you just the data set for the South Asian population because that is the cohort where there was a very strong agreement between both the UK and the Canadian registries. We did observe the same mutations in both of these registries. The allele frequencies were slightly different, but the mutations that were most frequent largely matched up between both of these registries. And as you can see, there's a large diversity, and there are several mutations with an allele frequency of at least 1% to 10%. So huge diversity there. And then also one other fact to notice is that there's probably several mutations that have still not been characterized in the South Asian population. And you also, I'm not showing you the data here, but you also see a similar occurrence when you look at the other Asian population. Unknown mutations are very, very frequent within the top 5 when you look at the allele frequencies. So then this raises the question of, how does the presence of all of these diverse mutations affect the diagnosis and treatment of CF in Asian patients? So to look at this, we first looked at newborn screening panels, because that's a very common way of diagnosing CF patients at birth, widely used in many countries. And so we asked this question of, what percent of patients have 2 mutations that are not present in a commonly used screening panel? So the first panel we looked at was the hologic panel. So it's a 39 variant panel that's commonly used in the US. And when we performed our analysis, we noticed that about 40% of South Asian patients and other Asian patients tend to have at least 2 mutations that are not present in the hologic panel. And when we look at the EU2 panel, which is a 50 variant panel, you still come to a very similar conclusion. The overall numbers are maybe slightly lower, but not that much lower. So overall, about 40% of Asian patients with CF tend to have two mutations that are not present in both of these very commonly used panels, suggesting that there may be delays in diagnosis of Asian CF patients. And so then we also asked this question of, is this something that we can readily fix? And so one of the solutions we explored was to see if we can just add some of the most frequent mutations that are seen in at least the South Asian cohort into one of these panels, and whether that improves our detection rate. And indeed, adding the 6 most frequent mutations present in South Asians into both the hologic and the EU2 panel ended up taking our detection rate from about 60% to close to 80%. So that is one potential solution to improve the diagnosis of Asian CF patients. And then there's also this other question of what fraction of Asian CF patients are not responsive to modulator therapies. And so we looked at what fraction of Asian patients have 2 mutations that are not known to respond to modulators. So when you look at the UK registry, strikingly about 50% of South Asians end up having 2 mutations that are not amenable for modulator therapy. It seems to be slightly lower in the other Asian population. And then when you look at the Canadian registry, you see that about 40% of both South Asians and other Asians end up having 2 mutations that are not amenable for modulator therapies. So that means there's a high unmet need in terms of the need for new therapies in this Asian CF population. And this is mostly driven by the high prevalence of nonsense mutations and large deletions that you observe when you look at the mutation frequencies. And so to conclude, CF does affect Asians, but it seems that it's particularly highly prevalent in the South Asian population. So that's something that we may need to pay attention to in the future. And then the mutations affecting Asian CF patients tend to be considered rare mutations. But if you look at the glass half full scenario, 50 to 60% of South Asian patients or other Asian patients can still be treated using existing modulator therapies. So we should be making efforts to make sure that these patients are getting access to those therapies. But in addition, when you look at initiatives like Paths to a Cure and other strategies to treat patients who are currently not amenable for treatment using modulators, they may be particularly relevant to Asian CF patients. And so that's something we may want to keep in our minds as we think about these programs for our own work. And so with that, I would like to acknowledge all the students who worked on this project in the Center for Asian Health Research and Education at Stanford, and the CF Foundation in the US, the UK CF Trust, and CF Canada for sharing their registry data with us so generously. And with that, I'm open for questions.
Thank you for very interesting, very important talk. We do encourage, if you're viewing, please submit any questions you have. I do have a first one for you. And given that your talk really follows nicely after Margaret's with the newborn screen, do you, and especially with the idea of adding sort of a wider gene panel to cover the mutations that South Asians are more likely to have, do you think that's something that could be implemented, across the UK or Canada or the US? And do you have any recommendations for that?
Yeah, so this is a very interesting question, and I've been sort of, whenever I get a chance to meet with somebody working more closely in the newborn screening space, I kind of so there are a few factors, right? So one is so the reason we looked to see whether we can just add a few mutations and improve the detection rate was especially because we thought that would be a little bit more achievable than pushing full CFTR states, right? Like most Asians, I think, live in California, New York, Texas, and Hawaii, I think, is like probably has the largest CF patient populations, and 2 out of the 4 do full CFTR sequencing already, right? So the question also is, is it worth the extra effort to do full CFTR sequencing for a state where only 1% of the population is Asian? And so that's partially the reason why we thought we could just add in a few of these mutations. But I think we've really only done a good job characterizing the South Asian mutations. So when you look at the US registry and look at the disaggregated data, there are mutations that show up in the Asian category that we're not picking up from the UK registry or the Canadian registry. So I almost wonder if there's like further, an additional Asian population that we're missing. And so, but to your point, yes, so that could be feasible. The UK does it a little differently. So they actually say that if you are going through the newborn screen and you meet the IRT criteria and their mutations come back negative, if the patient is Asian, they specifically send them for further follow-up for CF because they recognize this disparity. And so in fact, when you look at the prevalence calculations from this UK data set versus the Canadian data set, the UK data set has like a 4 or 5 times higher prevalence than the Canadian data set. And you almost wonder if that's because they have gone through that extra step to make sure that they're not missing these patients.
Oh, interesting. I think that's a good solution for the disparity. That's interesting that they're already doing that.
Yeah.
We did get a question from Theta Ong. She said, thank you, Dr. Vaidyanathan. Do UK and Canadian registries capture South Asian versus other Asian by self-report? Also, given the overall lumping of Asian in the US, would you recommend alternate constructs for self-report to be more parallel to these registries?
That's a very great question. I'm not 100% sure if they were self-reported or if they were, reported by the clinical staff in those registries. We just looked at how they were classified in the registry. So I don't have a good answer for that. But in terms of disaggregating the US population, yeah, I think better disaggregation would help us understand some of these nuances a little better. The challenge right now is that, so we are trying to disaggregate the US data set, but because it's self-reported, we are running into these issues of some patients, people from some parts don't feel Asian enough, and so they don't tick the Asian box and they tick the other box. And so, for example, when we looked at the known CF patients at Stanford, 50% of our known Asian patients don't show up as Asian when we look at the registry data for whatever reason, right? And I don't know if it's because of the clinician that they met with put them in the different box, or if they check the other box. So there's definitely more work to be done in terms of disaggregating Asians, because they are lumped together and they're not necessarily all the same, as we saw with this work.
Right, very good point. We got a question from Grace Paul. How do your common mutations compare with reported mutations from the Indian subcontinent?
So this is another great question. They do map pretty well in terms of the fact that there are really high, there's really high incidence of nonsense mutations that's already been reported. What was missing was the allele frequency. So now we also have a better idea of the allele frequencies. But that said, right, there are some mutations that have not been reported. So for example, L218X has been reported, but I don't think it was necessarily reported from India. I think it might be more associated with Pakistan. We just don't know. So there's definitely room to also further disaggregate populations from within Asia, to Dr. Paul's point. Yeah. And then some of these other mutations, like some splicing mutations, were actually reported originally from Iran, but they're also showing up in the South Asian cohort. But surprisingly, they were not showing up frequently enough in the other Asian cohort. And so I just don't know if it's because there are not that many people from like Iran and Arabia who moved to the UK or Canada versus, maybe more South Asians are mobile. So we just don't know. There's definitely certain discrepancies in terms of what we're seeing in this data set.
Right, interesting. We did get another question from Brandy Wagner. Great talk. You mentioned that the prevalence of CF in the other Asian group is lower than South Asian. Do you think this is potentially due to misdiagnoses?
That's a really great question. And it's possible because when you look at papers published from, say, Jordan or Saudi Arabia or like some of the Middle Eastern countries, they do say that they have a high prevalence of CF. So there are only two possibilities, right? So one possibility is not enough people are moving to the UK or Canada from those places, and therefore they're not showing up in the registry data set. Or the other possibility is they're being missed. Now, in the UK, they're specifically saying that if this person is, coming back negative for the mutations, but they're from some part of Asia, you need to follow them up further. So I would just be a little surprised if they're not cognizant of the fact that then, that they're not accounting for people from like other parts of Asia as well, right? So I don't have a good answer for that, but I do see that disconnect as well, because when you look at the papers from some parts of the Middle East, they do report a high prevalence, but we're not seeing that with this disaggregated registry data set. Further complications, I don't know if every country categorizes people from the Middle East as Asian. For example, in the US, for historical reasons, people from the Middle East are categorized as white as opposed to Asian. So I don't know how much of that dynamic is there in some of these other countries.
Right, that actually opens a can of worms for the comparisons. We did get another question from Alexander Albert. And it got voted by audience members. Interesting presentation, thank you. Have you tried to compare genotypes of the entire Asian registry population between UK and Canada from one side and the US from another? Are they similar?
Yeah, so they are similar. So some of the more frequent mutations that we see in the UK registry and the Canadian registry, they do show up in the Asian category from the US registry as well. The allele frequencies are a little bit off, but I think partially the explanation is I don't think we're accurately putting all of the Asian CF patients in the US into the Asian bucket, but the mutations are all there, and they're relative, the more common ones are there at higher frequencies in the US data set. The one discrepancy that I would say is that there were a few mutations that were present in the US data set that didn't show up in the UK and the Canadian data sets. And I don't know where they come from. And that's partially the reason why I think that it would be interesting to disaggregate the US data set further, because if there's a population from Asia that's more likely to move to the US than to those other two countries, we may not be picking them up in those registries, but we may be picking them up here.
Right, that's a great point. Well, I think that covered all of the questions that our audience had. Thank you so much. Very interesting topic. And we appreciate you presenting with us today.
Of course. Thanks for having me. These were great questions. So thanks.
Hi, my name is Adele Coriotti, and I'm a postdoctoral fellow with Dr. Anne Stevenson at St. Michael's Hospital in Toronto. First, I would like to thank NACFC and the moderators for allowing me to present my project. I will be presenting the international comparison of survival in cystic fibrosis between Canada, France, Australia, and New Zealand. As you can notice from the title, we have added New Zealand. That's because when the abstract for NACFC was due, we didn't have their registry data yet, but it has always been our initial plan to include New Zealand in the international comparison. There are no relationships to disclose related to this presentation. Throughout the year, survival in the CF population has increased significantly. This increase is a result of all the therapies and medications such as pancreatic enzymes and antibiotics, as well as the discovery of the gene causing CF, the CFTR gene. Some suggest that modulators, a life-changing therapy which corrects for some of the CFTR mutations, will be contributing to an increase in survival in CF. However, it is well known that survival in CF varies from one country to another. To understand why we see this difference in survival, it becomes important to conduct international comparison. This comes from a study that was published in 2017 by Dr. Anne Stevenson and her group, where they compared survival in CF between Canada and the US. On this graph, we have the year on the x-axis and the median age of survival on the y-axis. You can notice that throughout the years, median age of survival in the US has steadily increased. However, when we compare to the CF population in Canada, the rate of increase is higher in Canada when compared to the US. The authors concluded that the median age of survival was 10 years greater in Canada than the US. Also, the author suggested the healthcare system and access to lung transplant contributed to this survival difference. Following this study, we decided to compare survival of the CF population in countries where the healthcare system is comparable. So our hypothesis was that survival will be similar between countries after adjusting for differences in patient characteristics. And the objectives of our study were that to compare demographic and clinical characteristics between Canada, France, Australia, and New Zealand, as well as compare survival between countries. To do this study, we needed access to data from all 4 registries. As you can notice, the Canadian CF registry is the longest running registry, whereas the New Zealand CF registry is the youngest registry, having just started in 2011. The French CF registry follows the most patients, and all registries capture more than 90% of their corresponding CF population. Once we obtained the data from the registry, we had to harmonize them, meaning we needed to define the variables so we are comparing apples to apples. You might think, why not just compare the data available in the registry reports that are published every year? Well, that's because each registry has its own way of defining the variables. For instance, one country might be capturing the best lung function versus another that might be capturing the most stable lung function. Once we defined the variables, we extracted data such as demographic and clinical information from each registry. As you might already know, within big registries, there are always a small amount of errors, so we had to do some data cleaning. These discrepancies were sent back to the respective registries' personnel so that the data are cleaned at the source. Actually, those steps were the most time-consuming in this project. Once the harmonization was completed, we merged the registries and proceeded with the analysis. Now, for the study period, although we had data going back to 1992 in some of the registries, we decided to use a more contemporary time period. Therefore, we used the 2015-2019 5-year window. To compare survival, we produced Kaplan-Meier survival curves, and then to adjust for patient characteristics, we used the multivariable Cox proportional hazards model. First, I will present the patient demographics for each country. As you can see by the numbers under each country, France has the most patients in their registry, whereas New Zealand has the least number of patients. The proportion of women is around 50% for each country. France has the lowest proportion of patients with the Delta F508 homozygous genotype. Newborn screening is lowest in Canada, but that can be explained by the fact that newborn screening was introduced much later in Canada compared to the other countries. In addition, the proportion of patients that are diagnosed at less than 2 years of age was the lowest in Canada, which can also be explained by newborn screening. And finally, the proportion of pancreatic insufficient patients was around 80% in all countries. Now, if you compare clinical characteristics in each country, we observe that Australia and New Zealand had the highest lung function. In fact, they also had the lowest proportion of patients with an FEV1 lower than 40%. As for nutritional status, the proportion of underweight patients was highest in France, and that can be explained by the fact that in the general non-CF population, people in France are much thinner than individuals in the other 3 countries. Finally, we have the vital stats and transplant in each country. When looking at the age at last visit in the 5-year window, CF patients in Canada were a little older. Now here we have the number and the proportion of deaths for each country. What is interesting is that the proportion of deaths without transplant is higher than the proportion of deaths post-transplant for all countries except for France, where we observe the opposite. And finally, for the number and proportion of transplant, we see that France has the highest proportion of transplant. Now that we compared demographic and clinical characteristics, we can now move on to the overall survival comparison between the countries. On the x-axis, we have the age of survival, and on the y-axis, we have the overall survival probability. What was interesting is that the survival curves for Canada, Australia, and New Zealand were all overlapping, while the curve for France was distinctly different from the other countries. In fact, the median age of survival was the highest in France. However, this model does not take into consideration demographic and clinical characteristics. Finally, we assessed the risk of death between countries after adjusting for the differences in patient characteristics. Since New Zealand only had 21 deaths in that time period, we did not carry it out into the Cox proportional hazard model analysis. For this analysis, all patients were included, which included all pre and post-transplant deaths. In our model, France was set as the reference country. In the univariable analysis, we found that the risk of death was higher in Canada and Australia when compared to France. In the multivariable analysis, we adjusted for static variables such as sex, age at diagnosis, newborn screening, pancreatic insufficiency, and lung transplant status, and observed an increased risk of deaths in Canada and Australia compared to France. You can notice that we did not adjust for clinical variables such as lung and nutritional status, and that's because lung function measurement represents a different disease process after lung transplant and no longer represents CF lung disease. So we felt it was important to censor at transplant. By excluding post-transplant deaths in patients who had received a lung transplant before 2015, we found in the univariable analysis an increased risk of death pre-transplant in Canada and Australia when comparing to France. Finally, when we adjusted for the static and clinical variables in the multivariable analysis, you can see that the hazard ratio for Canada and Australia remains high. Now, the key findings of our study are that median age of survival was the highest in France compared to Canada, Australia, and New Zealand. Despite the demographic and clinical differences identified, people with CF in Canada and Australia were at higher risk of death than their counterpart in France. The strength of our study are that we have relatively large sample size registries, and they are also very well characterized. Moreover, there are very few loss to follow-up in the registries. As for the limitations of this study, our survival analysis have not yet been adjusted for medication, microbiology, and socioeconomic status. Finally, this is a registry-based study, so we expect it to have some missing data. Therefore, to minimize the missing data in each registry, we will be doing multiple imputation. How can we explain the fact that France has higher survival than Canada, Australia, and New Zealand? Could it be that people in France live longer? Actually, we found that the life expectancy in the general population in 2019 was similar between countries, so would not likely explain the difference in survival in the French CF population. How about the contribution of healthcare to the gross domestic product, the GDP, in other words, the proportion of money spent on healthcare? As you can see in this bar graph, there is a spread in the percent GDP between the countries, with France spending the highest proportion of money for healthcare, which may be contributing in the survival gap. What about the coverage of CF medication between the countries? It might play a role in the difference observed because CF medication coverage is different between countries, in a way that some countries have complete coverage, whereas in others there are some barriers in access to medication. Other explanation could be the geographical distance of CF centers. France is a small country and it has the most CF clinics among 4 countries. So this means that CF care would be more accessible to CF patients in France. In other words, it becomes potentially easier for patients to get to their CF clinic. Finally, what about the approach to transplant? As a matter of fact, France has a high emergency transplant program that allows for the sickest patients to have access to lung transplant faster. However, Canada, Australia, and New Zealand have more of a country-wide universal and systematic program, which might also explain the survival difference. This project could not have been possible without the collaboration and involvement of all 4 CF registries. I would also like to thank the CF patients and their families for allowing us to use their data in the registries. Finally, thanks to all the fundings shown at the bottom of this window. Thank you.
Thank you, Adele. That's a very interesting comparison of the data from those different countries. While questions come in from the audience, I had 1 or 2 here. The first one being, with combining the registries from different countries, what was the biggest challenge you found? And then my other question is, will you be adding other country registries, or are you going to keep it with the 4 that you did?
That's a great question. Thank you, Anna. So I think the most challenging one was defining the variables, because like I noticed during like I mentioned during the presentation, every registry has its own way of defining the variables. So trying to find one specific definition that would be appropriate for all 4 registries, that was the most challenging one. And also if there were any missing data, then we had to ask for each registry to go back and try to get that data so we can have them as much data as possible and complete the data sets. And what was the second question? Sorry.
Oh, if any other countries maybe would be added?
For now, no, I don't think so. But eventually, yeah, like because we have the basis, we have everything already set for doing this type of analysis. The only thing would be to define the variables. So for now, our objective is not to add another country, but it could be possible in the near future. Thanks.
That sounds good. Yeah, it's interesting. Do you see, especially with the differences between France and the other countries, do you see there being differences in the ways, for example, like transplant or medications are recommended or considered in other countries such as Canada and Australia?
Yeah, so that's what we're hypothesizing right now. It's that it might be transplant, because like in France, they have this high emergency transplant program. So they're transplanting a lot of patients way faster. And it's like the sicker patients are getting transplanted. And whereas we don't really have that in Canada or in Australia and New Zealand. Medication coverage, well, in France, they have they cover medication, like a very wide range of medication, whereas it's not really like entirely the fact in Canada and Australia and New Zealand. So I would think that, yeah, they might contribute to this survival difference.
Perfect. We did have one question come in from the audience. Mirana Lim asked, any role for a global registry?
Oh, that's a good question. I didn't think of, once we get everything, once we understand why there's this survival difference, then maybe they might see our project and be interested in to try to get more information. I would hope so in the future.
Yeah, we did get a question from Margaret Rosenfeld. What about socioeconomic status as a potential explanatory factor?
Yeah, that's a really good question. And we, like I said, one of the limitations is that we did not account for socioeconomic status. And I would think that that would be one factor that could contribute, because I just saw a study that came out not even a month ago in the European Respiratory Journal, where they compared countries within Europe, and they saw that socioeconomic status actually contributed to survival difference. So yes, that's an important factor that might explain the difference, but it's yet to be captured, like analyzed and in the near future. Yeah.
Great. And then we got a comment from Maggie McGowan. All 3 countries use the same airway clearance techniques. However, in France, a physiotherapist comes to the patient's home 2 times per day to do airway clearance, while in Australia and Canada, patients and their families are responsible for doing airway clearance at home. Hence, adherence is higher. How do you think that's impacting your analysis?
It might be. Like, I didn't know that. So that's very interesting to know, because in registry data, you only know if they do like physiotherapy or not, or if they have home oxygen or not. So it's not that specific like information where we can compare between registry. But yeah, if knowing that could contribute to the survival difference, of course. That's a great question. It's good to know. Thank you.
Well, I think that were all the questions from the audience. So thank you very much, Adele. And I would like to take some time to thank all of our speakers for joining us today, and the audience as well for your live questions. That's great. And then I also want to give a big thank you to Jenna Sykes, my co-chair, for helping out with every stage of chairing my first session at NACFC. So thank you all, and have a great rest of your day.